Good morning, everyone. Thank you for joining us this morning. I'm Brooke Thomas. I'm your CME specialist with Community Hospital. Today we have Dr. Nick Monson presenting to us on acute injury management. A few housekeeping items before we start. If you have any questions for Dr. Monson, please add those to the chat. We'll answer those throughout the presentation, and it will be interactive, so please join us through the chat and make comments. We love it. Dr. Monson has a disclosure that he is a consultant for Avanos Medical, and this has been mitigated. Community Hospital designates this program for a maximum of 1 AOA Category 1A credits and will report CME and specialty credits commensurate with the extent of the physician's participation in this activity. Excuse me. Community Hospital also designates this live activity for a maximum of 1 AMA PRA Category 1 credits. Again, physicians should claim only the credit commensurate with the extent of their participation in the activity. Dr. Monson went to med school at Des Moines University and completed his residency in family medicine at the University of Utah. He completed his sports medicine fellowship at the University of Utah, graduating in 2014. Dr. Monson completed 2 years with Davis Orthopedics prior to returning to the University of Utah to join the Ortho Group and Sports Medicine Fellowship faculty in 2016. Dr. Monson serves as the team doc for University of Utah football, lacrosse, Utah Jazz, Salt Lake Community College, as well as the director of orthopedics for the Farmington Health Center and provider at the Snowbird Medical Clinic. Dr. Monson has 3 children and an awesome wife. He is an outdoor and sports enthusiast with active research interests in concussion and usage of cell therapies, primarily focusing on PRP. Okay, Dr. Monson, the floor is yours.
Thank you very much. Good to be back with everybody again. Acute injury management is a super, super broad topic. So as I started to go through and kind of prepare this lecture, I decided it's probably best to focus mainly on upper extremities today, so that we can go through acute injury management options regarding that. There are some principles that we'll talk about for other areas, but it's a super broad topic with lots of opportunity for input from everybody that's listening here today. So if you would like to give me input, please, by all means, you won't derail the conversation at all. I'd love to know what questions or experiences you have. I looked through the reviews from the last lecture that I gave, and it's kind of tried to get an idea of who I'm lecturing to. Obviously, there are some sports medicine physicians, some primary care providers, kind of a diverse background of what kind of medicine you might practice in different settings. So I think everybody probably has different experience levels and different comfort levels based off of that. One of the goals that I have today is that people can come away feeling just a little bit more comfortable with providing some of the acute injury care that could be provided fairly easily through primary care. But I will say that also never should you feel like you need to practice outside of your comfort level on anything. So that being said, the disclaimer that Brooke already mentioned, existing contracts for Trice Medical and Avanos Medical. And I won't mention anything for either of those. Okay, so talking about acute injury management, and this could probably be a lecture in itself. In fact, when we have our fellows, we often do talk about this for almost an entire lecture, just talking about the settings and the conditions. I work up at Snowbird. At Snowbird, we're in a clinic setting, and it's basically run like a small little trauma bay and urgent care. But part of my duties have been working with the U.S. ski team. And so there'll be times that I'm covering an event out on the mountain or the half pipe or whatever it is. And those situations bring up all kinds of things that you may not think about, just for the fact that you're going to be on the side of a mountain and somebody goes down and you're on skis. And number one, you better know how to ski down to them and not crash into them. Especially since like a slalom course, they just ice those things down as much as they can. They get as much speed as possible. And so trying to stop, you have to kind of know the conditions so that you're not just sliding right past the person or into the person that you're trying to see. Um, the office setting, obviously, you know your equipment, you know what you have available. But I often carry a medical bag with me when I cover different events, and that medical bag is pretty big, and there's a lot of different pockets, and trying to know what's in each pocket and what's available to me through that to help out with more urgent settings is helpful too. As you have heard in the bio, I cover lacrosse, I cover football, and I cover um, the Utah Jazz. And the Utah Jazz, we have a full medical room that has all of our equipment in it. And every year, I don't necessarily even have to do it all because there's a whole team that will take care of. Are the medications up to date? Is the lidocaine still usable? Is uh, um, the AED up to date? And then on lacrosse, I bring a medical bag with me, but the different kinds of sutures and different things that will be required through a game, I have to keep up to date. And just try to make sure that you know everything available. Uh, Covering a swimming event, how do you get into a pool and access somebody that hit their head on the turn? Which it sounds silly, but I don't know how many swimmers I've seen with concussions now at the university, just because they make the turn and they accidentally hit their head on it and come out with a concussion. I don't think that speaks towards the skill level of the swimmers at the University of Utah. I guess it's probably somewhat common everywhere. Looking for confirmation there. Uh, I went to a lecture in Vegas, and I spoke to the doc that was the Cirque du Soleil physician. And the things that he brought up were just insane that they had to think about because they have one of their things is a big trampoline floor, basically. And think about if somebody goes down with a head injury or neck injury on a trampoline, how do you even get out to them without shaking the whole trampoline the entire time and causing all sorts of disruption to that person? So they actually put out boards that they walk across the boards so that it's not creating a whole bunch of motion that could otherwise further injure a neck. Um, Nitro circus is something that I've covered on several events, and every time I cover it, I think, wow, this is really fun. But boy, is this stupid, both for me to cover and just crazy for the talent and the skill level that these people have. But the risks that they take to do it. One of my uh, stories that I'll tell people is I covered a Nitro World Circus. This is probably like 5 years ago, or yeah, I think it was like 2019. Um, I was going out to one of the practice sessions where they were practicing all their massive tricks. This was for FMX. These are the guys that get on the uh, uh, dirt bikes and then throw down just massive tricks off of a huge jump, and then try and land it. They have kind of an inflated landing pad. Um, and I'm driving out to the track, and an ambulance passes me on the way out, and I'm thinking, oh boy, this isn't a good start. There's already an ambulance going out there. And I get out there and I go into the medical room where the ambulance is pulled up, and I had one of my fellows out there covering the event before I arrived. And I walk in the room, and he's passed out in the corner, and we have the an athlete on the table just screaming and writhing in pain, with a femur fracture and obvious deformity of his femur. Everything's closed. But I walk in and I say, "What's going on?" He's like, "Oh, this guy's in terrible pain. Your fellow was trying to help out, but he got so anxious and so nervous, and it was, the guy's in so much pain that he had to go lay down for a minute." And so I had to jump in and start helping out in that situation, get the guy in traction and get him some pain medication, and basically just fly him out. Knowing that there's not a lot that we're doing except for providing that initial care to make sure that the neurovascular exam is intact and everything else is good. And then in a lot of those situations, there's the televised component to it. A lot of this stuff is not necessarily uh, anything I'm worried about telling you because it's been televised, but like Udoka, one of our jazz players, kept dislocating his ankle. And this happened several times in games. And his ankle dislocates. It was a subtalar joint that dislocated, and I go out there to help them out, but it's all on TV, and so there's a lot of optics that go into that. What do people want to see? And actually, this just happened a couple nights ago. We played Dallas last night and spoke to their medical staff. But when we were down in Dallas, which I don't travel with the team, I just cover the home games. But when the Jazz were down in Dallas, the one of our second year players, Taylor Hendricks, had a bad injury to his lower extremity, and you watch that flop around on TV, and everybody, the optics are really tough. So trying to figure out the right way to approach that and I deal with those athletes in the moment of their need, but also trying to make sure that you're providing care that's appropriate for them and that they're not feeling overly exposed. In those situations, as often as I can, like if somebody dislocates their shoulder in a game, I will try to bring them back into the med room, into a tent, into wherever we have a more private setting, and allow them some privacy and a chance to kind of cool off a little bit. When they're in front of a crowd, they either feel the need to be tougher than necessary, or sometimes they are just overly hyped and they can't actually relax their muscles. They can't calm down. So giving them just a couple minutes to breathe, to talk to them, to distract them, to let them know that we're going to be able to take care of them is super helpful in being able to have a successful treatment. Um, the other thought process on this is what kind of resources do we have available, such as like a emergency action plan. So going into these events, going into things and knowing what your resources are available. Where is the closest AED? Where is the ambulance going to be located? Where's the nearest hospital? And having you and whatever other staff or providers are around aware of that, even assigning beforehand, okay, who's going to manage airway, who would do chest compressions, all thoughts that are very helpful to have. I've done training with ATLS, ACLS, and then obviously part of that comes with that is BLS. So having the background training of knowing what to do in these situations is helpful. The ATLS training, I feel like the entire course that I took was send them to the hospital. Basically, every time that there is an issue, you need to know, get them to a hospital. This is the most important step, is to get them to a next level of care, because whatever care we're providing in the field is going to be just a start. And clearly, if we're worried about them, they need to be moved on. So basically, a lot of the action plan is making sure that you're getting to somebody that's a caring provider that has the knowledge and background of what to do with this. And then really what it all comes down to in the end, as far as limb saving or injury saving, is what's their neurovascular exam. You want to make sure that they have blood flow to the area and that their nerve function is appropriate. If they don't, then it means that your initial treatment needs to be much more rapid and that you are basically in the driver's seat to go ahead and try and make something happen. If their neurovascular exam is intact, if they have pulses, if they have good cap refill time, if they have full sensation and ability to move the extremities in the way that you would expect, then you can delay treatment until they receive another level of care. And then don't forget, good old Regis, phone a friend. There's always that ability to try and call or answer this in a different way. And I say that somewhat truthfully. Sometimes phone service is not available. I was in the backcountry and there was a guy sitting on a rock and he had his shoulder dislocated. He's like, I've never had this happen, but my shoulder just dislocated. And I was a resident at the time. And I had been working up at Snowbird on several occasions already at that point. So I had reduced a couple of shoulders. So we reduced his shoulder in the backcountry just using a shirt and some MacGyver techniques. But most of the time, if you can phone a friend, it's very helpful. All right, let's go through a case. This is, working up at Snowbird. I don't know how many shoulders we have to reduce, but I'm sure I've reduced hundreds of shoulders at this point, just because people get on those snowy conditions, and it is not uncommon to have something go awry. The arm gets outstretched, and boom, a shoulder pops out. As a fellow, we took a video of shoulder reduction using what's called the Snowbird technique, and it's been published as the Snowbird technique. It's still the technique I use the most. And this is a little video of the reduction technique. There are many ways to reduce shoulders. And at the end of the day, whatever your comfort level is with it, but this will give you an idea of one way to reduce a shoulder. All right. So on that, on the shoulder, you could see the deformity that he had, the little sulcus sign through here. You can see that it's a multi-person technique doing it this way. So usually we use like a little stocking net and wrap it around the patient's elbow and then tie a loop on the other end. So it's a loop and then put my foot in it, provide direct downward traction by putting my foot through that loop and then holding the patient's elbow bent up a little bit past 90 degrees. And then as I'm providing that downward traction, a little external rotation of the shoulder and maybe a little abduction helps that glenoid slide back in, or the humeral head back into the glenoid. Um, it's also helpful when you have somebody up above. So they'll either grab a towel or a sheet and wrap it around underneath the axilla of the patient and help retain that area so that the patient's not falling with me providing that downward traction. Um, it can go in within like 5 seconds. Sometimes it takes a good 20 or 30 seconds and just providing that constant downward traction. And then a lot of conversation with the patient as we're doing that. So there's a lot of discussion of just breathe through this, make sure that you relax those muscles as much as you can. If you feel them just really hanging on tight and they're not letting go, it's going to be really hard to reduce that. And I feel like as a provider, it's one of those things that I'm telling them to relax. And I feel like a jerk, like, yeah, just relax, it's all good. And it's not that easy for them to relax through that moment because they're in a lot of pain. But the second they let go of those muscles, boy, it just gets so much easier to reduce it. Which, that being said, there's different tricks of how to do that. It's important to get some films before and after a reduction. It's not always possible to have films before a reduction. The main purpose of that is to evaluate whatever fractures may pre-exist a reduction. Even if a shoulder has a fracture, let's say there's like a greater tuberosity fracture, uh, you're still going to do a closed reduction, just using any technique that you find most helpful. And often those fractures that look like they're pretty far apart reduce significantly once you get the shoulder back into joint. So the only case where that may change is if there's a large surgical neck fracture. And even then, most of the time, we'll try and get those back in, but it might change our approach with it using a trauma service to help us guide that process. Post-reduction exam is very important in this. With a shoulder dislocation, you're worried most often about the axillary nerve because of the proximity that it can get pinched when it dislocates. And the axillary nerve, just sensation over the deltoid region is a good way to test for that. And then just ability to gently abduct. Everybody's going to have some amount of weakness after just from pain inhibition alone. So I don't expect them to have full strength, but I want to see that they're able to abduct and that they have sensation over the lateral shoulder. Somebody that's dislocated, if they come into you and they did it 10 hours ago, the chance of you getting a reduction easily in the office is going to be pretty limited. If they did it in the last half hour to an hour, we don't do any analgesia or sedation. We just go straight to the reduction because it's so fast and so easy that by the time you provided them with an IV or other means of treatment, it's typically not necessary. They've gone through more time and more pain. That doesn't mean that you don't have to. If you have something that you feel more comfortable, that you provide some means of sedation or analgesia beforehand. That's totally up to each provider. Many different types of reduction techniques available. Listed a handful of them here. Again, if there was one that you felt more comfortable doing that you had done with success before, that's fine. My success rate with snowbird technique is like 99%. I've had maybe one or two patients where I was unable to get it and ended up having to do sedation in those cases to get it back in or to use an alternative method. Putting an intra-articular injection is totally an option if they're struggling. They create a nice sulcus, and that provides a nice area that you can easily inject into the joint and provide some analgesia into the joint and give that some time to settle in, and then try the reduction again thereafter. And then, granted, I don't think most people will have sedation abilities. We have a full nursing staff up at Snowbird, where I can provide some ketamine or some Versed or fentanyl to help provide some further sedation if we need to get somebody more sleepy to get it back in the rest of the way. Any comments or any questions on any of that before I keep moving on? All good?
I'm not seeing anything yet.
Okay.
Thank you.
Um, yeah, I would suggest that if you have not done a shoulder reduction, it is a process or a procedure that many people see one, do one, can do. It is something that, as long as you catch them fresh enough and somebody has that comfort level, then providing care with a shoulder reduction is something that you could certainly discuss. If there's any concern, I would not push you to try and do a shoulder reduction, having just watched a video on a lecture once, but the technical aspects of it remain fairly minimal. Let's talk about some more shoulder injuries. And I get a lot of referrals for just post care, especially coming in the next month. We'll see a ton of shoulder injuries just from the ski hills. Um, and these shoulder injuries, a lot of them are very simple to care for, but there are some basic principles to know. So we'll go over some of those basic principles and hopefully give you some comfort level about what needs to move on and what you are welcome to continue to follow through your clinics. Um, the AC joint, the acromioclavicular joint. So you have the clavicle goes up and meets with the scapula at the AC joint. And there is a thick ligament that goes across the top of that joint, the AC ligament. And then you have two very large and very important ligaments here, the trapezoid and the conoid ligaments. And these really help support and bring down that clavicle so it stays in the correct position. And this is really what we worry about with surgery. This ligament here often will scar in and will heal regardless of what the injury is. So rarely is this one repaired, but these are the ones that are repaired if there's a more major injury. And I don't expect you to remember all the different types of AC joint separations, but I just want you to know, when do you say, this is outside of my league and I need to do something else with it? Um,
Dr. Monson, we do have a question.
yeah.
When you say neurovascular evaluation, many patients say they have numbness after an immediate injury, but how do you know it's truly concerning?
So strength would be one big part of it. So when I'm looking at neurovascular, sensory is important, and I would do a side by side comparison. If you have a monofilament and you want to do more accurate testing, especially if it's like a hand injury or something, I do think that's helpful because then it can give you a distribution of nerve injury. I think being aware of the dermatomes is helpful because a lot of patients will say, my shoulder hurts, and it goes all the way down through here and like wraps around and kind of goes up through my ear and then around to the other. They're basically describing something that is not a typical nerve pattern, but more of a referral pattern of pain. And if they're leaving a particular dermatomal pattern, my concern for a particular nerve injury certainly lessens. So just being, and it's pretty simple. If you look up online as somebody, I don't know about you guys, and sometimes people will be explaining something and I'll drop back to the computer real quick and Google like, what the heck are they talking about here real quick to make sure that I'm not way off base. But checking out a dermatomal pattern is helpful, and then simply testing the strength of what those nerves would be doing, and making sure that those strengths are intact is a very helpful tool. Okay, so the physical exam for an AC joint is actually really helpful, really obvious. Skin to win on this one. Just make sure that you actually see the shoulder because it makes a big difference. If you see a big deformity there, it's pretty safe to say it's more than a grade one AC joint. And then they're usually really tender at that spot. And granted, it can refer to other spots as well, but it's an AC joint kind of pokes your eye out when you look at it. It's like, oh, yep, that's an AC joint, plus or minus other things. So don't forget that they can have concomitant injuries, but certainly you'd be expecting uh, pain at the site of the AC joint. Type ones are the maybe a little harder to diagnose in the fact that they don't necessarily have a deformity that you can always see. They might have swelling from the joint, but if you see them a couple of days after that swelling could resolve, they'll typically say like, "Hey, I was snowboarding and just kind of plopped straight over to the side, or skiing and I plopped straight over to the side." And then right after, man, it's just so sore through here. I can't sleep on it. It's hard to move my arm, especially crossing my arm over. Um, those are the things that really provoke them the most. In this situation, the AC joint is intact. The ligament's actually still intact, but they sprain it. So that ligament has basically partial tearing through it, but it's not completely torn through. All the musculature around it is still intact, and these big ligaments that we were talking about through here are perfectly intact. A type 2 is a little bit of a different story. At this point, you've now disrupted through that AC ligament, but these CC ligaments or the corticoclavicular ligaments are still intact. And so it hasn't really lifted up too much. It might go up to about 50% of displacement. So if you're looking at the x-ray, you might see this bone just 50% higher on this bone, but not more than that. Those are both totally non-operative care in all situations that I can think of. So if you ever have one of those come through, feel free to continue to follow those patients and not worry about it. It's controversial once you hit a type 3 injury. Type 3 are going to be once you've hit up to 100% displacement. So basically, the end of the clavicle lines up with the end of the acromion, and or the bottom of the clavicle lines up with the top of the acromion here. And if that's the case, whether they do surgery or not is controversial. I would say the vast majority of surgeons still don't do surgery on these so long as their exam is appropriate, meaning that their musculature and their pain is reasonable. Basically, it's a cosmetic discussion on these ones. In a lot of situations, they're going to have a pretty large bump, but they're going to trade that for a scar. Um, a lot of patients will opt to watch it and see how it does over the coming months. And then if they remain symptomatic, then people will go in and tie back down these ligaments here surgically to help bring that down. Um, Controversial, if you ever had a question on that, phoning a friend would be totally appropriate and seeing what they say. It can be surgeon dependent. Certainly, it should be a patient involved discussion as to expected outcomes of surgery versus not having surgery. Type fours, those are sometimes kind of hard ones to miss. They can actually look like a type 2 or a type 3. And what happens with these, I think the important part to know is that the clavicle actually gets stuck behind the trap. So your large trap muscle here, the clavicle will kind of shoot behind it. And you can see this on a film where it's really elevated and it looks like, wow, that's kind of weird. That's funky and off. But it's actually on the axillary view that it's actually a little bit easier to see. You expect this is, the humerus coming down on the outside of the arm here. This is the acromion here. This is the end of the clavicle here. And you expect the clavicle to kind of meet up in this zone here, but you can see that it's shifted backwards through here. And the easiest way to tell what it should look like is to get a view of the contralateral side. So if you had an x-ray of both sides, then you can compare and make sure that those clavicles are lined up correctly. You can also have the patient kind of move their shoulder around. And if it's stuck in the fascia, it's kind of an odd look to it. One of my partners actually had this happen to him and had me look at him. And I go, oh, I think you have a type 4, man. So these do have to have surgery. You got to pull that clavicle back out of the muscle and then tie those ligaments back down. A type 5 is now much more than it goes 100 to way higher as far as percentage of displacement. And those ones do need surgery. Otherwise, they really don't do well. At this point, they've lost a lot of the muscular attachment onto the bone. And then a type 6 is a pretty gnarly one. I've actually never seen this one, but this is where the end of the clavicle actually tucks underneath the coracoid process. So it goes all the way underneath the shoulder, and it's very disruptive. Pretty easy to see on imaging. And if you saw something like that, that would certainly be surgical. So types 1 and 2, for sure, I recommend you treat them in the office. And I don't think you need a huge experience or skill level to treat those. It's really more teaching with patients of the initial several weeks are often uncomfortable. Early range of motion is incredibly important on these. And then as they're feeling better, if you need to, you can progress them with physical therapy if they're having a hard time returning back to their activities or have concerns about position and function. But often just giving them a handout of a home exercise program is great. In the first week or so, if you want to use a sling for comfort, that is fine. You don't have to use a sling. Um, but most people will provide one for the first at least several days. And then after several days, I really start to push them on doing as much range of motion activity as they can handle. That usually involves like Codman's, little pendulum swings and circular motions that they just use gravity to kind of help their shoulders get gently moving more. And then as they improve with that, they can start wall crawls and they can start active range of motion thereafter. And that happens fairly quickly for the majority of the type 1 and type 2 AC joint separations. Um, so just going back to that, you're changing a scar for a bump, and even when surgery is done, only 50% of those cases remained reduced at follow-up. So uh, it's one of those things that maybe we're not as concerned about trying to push them to do that. Going to clavicle fractures. Clavicle fractures, super common bone to fracture. The vast majority of these cases are going to be non-operative. We'll go over that. We kind of group them into different areas, into the middle third of the clavicle, the distal third of the clavicle, and then the medial third of the clavicle. By far the most that we see are the middle third of the clavicle. And treatment tends to be non-operative in the vast majority. It varies if you talk to surgeons, if you look in the literature as to how aggressive people are on doing surgery with these. I feel like it's a constant like up and down. Oh, we're going to do surgery on this versus not. And so therefore, if you have questions, by all means, phone a friend. But there are a lot of these that really just don't need surgery. And you'd be welcome to follow these as well without even sending it to the orthopedist. There is no clear option on bracing that we strongly recommend. Typically, it's going to be the same discussion of a sling initially. You can do a figure of eight bandage as well, and basically just wraps around the shoulders and helps keep them a little bit further back. Um, Typically, the sling is what I'll use just because it's more comfortable for patients to wear. And it's a little bit more noticeable for other people around them so that they're not bumping and shoving into them on accident. The surgical versus non-surgical part of this has a couple of discussions. One is that if you do surgery on them, you're changing the bump for a scar again. And the second part is that typically it's done with a plate for hardware. And that plate sometimes becomes symptomatic for people afterwards because it's a very superficial area on their body. So they feel the screws, they feel the plate, and it actually bothers them enough that a certain portion of those people I've read in the literature anywhere from like 10 to 20% of people will move on to want the hardware removed thereafter. So it can become two surgeries. Uh, the biggest indication for when you should do surgery is some fracture patterns have a risk of non-union, and those are the ones that certainly would require um, surgery. Uh, Trying to reduce a clavicle fracture. Honestly, never really tried to reduce one. I don't think it's something that's very easily done. So if it needs to be reduced, it needs to be an open reduction under surgery. Um, they will typically heal pretty fast. So people will come in and it's pretty terribly painful for them in the first time that you see them. And then within a couple of weeks, most kids that have this happen, you're trying to slow them down. You're trying to remind them that they need a little bit of time to actually let this heal. Um, the ones that you worry the most about, significantly displaced is a very variable number to say like, oh, it's significantly displaced or minimally displaced because radiology sometimes call minimal and it's actually significant, et cetera. But what I'm worried most about on these ones is if the fractured ends have overlapped by more than 2 centimeters. I'll usually have my surgical colleagues take a look at it. So it's okay if the two ends don't meet up and one's overlapped by the other. And if it's less than 2 centimeters, I'll typically treat those non-operatively. If it goes more than 2 centimeters, that's about the number that people will start to get a little bit more anxious about how to treat them surgically versus non-surgically. 2.5 centimeters was the number that we used a while ago, and that seems to have shortened a little bit. And this is for midclavicular fractures. If it's a distal third, if it's out towards here, we can go over some information on it. But realistically, if you have concerns, that's when I'd send off to the surgeon. If it's mid-clavicle or medial third, then I think that it's fine to watch those non-operatively. Um, Elbow dislocation. This is another type of dislocation that I would tell you that in the office, for the most part, you would be okay to try and reduce these. Typically, don't require sedation. Typically, don't require an injection or anything prior to, because the reduction can be very quick and simple. However, anybody that was concerned would always be welcome to send this off for. I know my wife dislocated her elbow snowboarding years ago. And if I told her that I would treat this without sedation, she'd probably try to kill me because it was a rough experience for her. Um, Relocating technique that I'll typically use, again, I usually will use a two-person technique. So as long as you have two people, I have the patient lay prone on the bed with their elbow hanging over because that provides a good counterforce. And then somebody just kind of pushes. The vast majority of elbow dislocations, I think 90% are posterior. And so somebody just pushes up against the olecranon and helps push it this direction. And then somebody's giving an axial load while that happens. You can do the single person technique as well, where you can do both of those. And it actually is kind of helpful just to get the feel as both are going, because you can feel it slide back into place pretty easily. For the most part, these reductions are fairly straightforward. Overall, the recommendations on it are very similar to the shoulder. If you don't feel comfortable, send it off. If you want to do an intra-articular injection beforehand, they have provided a nice space where you know where the joint is to inject into, and you're welcome to do that, usually just using that posterior approach. And then just remember to get imaging on these pre and post. These are a little more common to have an associated fracture with them. And you're going to want to look at that medial epicondyle, especially in younger patients, because often they'll have a little associated fracture from that. And that would be just going back to the shoulders. I think about that would be an important thing. We do sling those patients, and I have them wear the sling pretty regularly, even during sleep for the first week, because chance of a recurrent dislocation remains fairly high at the start. Elbow dislocations are not as high on having that occur. So we don't worry so much about the elbow dislocations recurring, but the shoulder ones can recur in the first week, especially if they have a Bankart or another type of fracture that allows it to be more in and out slippy. Early range of motion in the elbow is also important. So as soon as they feel like they can, we try and get them moving. The biggest complications we see are patients that have a lot of adhesions that happen just because they've not been moving, and then you're spending your time trying to get better range of motion in there. Okay, let's go through some different types of fractures of the wrist, and this is I people have named the different types of fractures, and this is not necessary to remember anything. This is me just being nerdy and trying to see who knows the names of the different types of fractures here. So looking at this, does anybody know what kind of fracture this is?
Please enter them into the chat. Thank you.
I'll give you a clue. Silence. Okay, we're going to go with a chauffeur's fracture or a radial styloid fracture. Anything that goes into the joint, feel free to send on. These go into the joint. If they're non-displaced, they are treated non-operatively, but feel free to send those on if there's a concern. This fracture here, if anybody knows what this one is, I'll give you another clue. Yep, you got it, I'm sure. It's a Barton's fracture. Basically, it's a fracture where there's a usually a dorsal fracture that goes into the joint and often has a little dislocation to the radiocarpal joint associated with that. Those do go on to surgery. Okay, this one, I don't really expect you guys to know all the names, but I'm going to still give you a clue here. Everybody knows this guy, right? Good old Abraham Colley. So that's a Colley's fracture. That's the most common kind of fracture that you'll see. It's and just maybe a quick training so that you know how you speak about this to your surgical provider is you can name a fracture based off of the apex of the fracture or the distal fragment. So this distal fragment is dorsally displaced. So it's gone backwards a little bit, or you can say apex volar. The typical way that we'll talk about it is the distal fragment. So we'll say this is a dorsally displaced fracture, Colley's fracture, the more common type of fracture that we see in a wrist. Typically, these can be reduced in the office and treated non-operatively. And going back, the next type of fracture. Now, this is a similar fracture, but this one has gone volar, so it's gone forward. And that is not a sunglass fracture, it's a Smith's fracture. And then this one, this has gone into the lunate fossa of the wrist here. So there's a fracture pattern that's gone all through this lunate fossa, pretty bad type of fracture, and it's impacted. This is not a Mike Tyson, but a dive punch fracture. Again, the names don't matter at all. But these different fractures are, as long as it stays outside of the joint, they can often be treated non-operatively as long as they reach reasonable alignment. And again, low threshold to send on to others if you don't have a comfort level with it. Non-displaced fractures, especially if they're extra-articular, I would encourage that you could often treat these yourselves and not feel the need to send them on. And then other types of fractures, just to be aware of, that can happen in the wrist. You can get the Galeazzi fracture. What happens with this one is you dislocate the DRUJ, and when that dislocates, it's actually really hard to reduce these without doing surgery. So most of the time, I'll just send these straight on to my surgical partners to reduce. Again, looking at the neurovascular exam. So if they come in and they've lost, I could see discoloration in the hand, or they're unable to fire the finger muscles, and I'm concerned about like a median nerve injury, then I will attempt a reduction to at least try and get it into a better position before I send them on to the surgeon or to the emergency department to have it reduced. Another fracture is the Monteja fracture. This is one where the proximal radius dislocates. And this happens more often in young patients. And so you can actually often reduce these ones. I would not necessarily say that you have to worry about those, but they're actually as simple as often just pushing down on the radial head, because you'll see it kind of popped up, and you can push this down as you're applying traction to help bring the ulna back into better position as well. I had just a simple case that came into the clinic that I figured I'd share with you guys on. We talk about reductions and saying, yeah, this is something that you could theoretically do. This is kind of the case of how we do it. So this patient came into the urgent care. The urgent care called over and said, hey, would you be able to take care of them? They really don't want to go up to primary children's to have this reduced. It's a difference of thousands of dollars basically by the end of it. This is a both bone forearm fracture, kind of a green stick deformity that we can see to the ulna here, and then a more obvious fracture through the radius here, maybe a little comminuted. And on the different views, we can see that there's a pretty significant inclination to the distal radius, especially. So I talked it over with the parents, they and the kid. 11-year-old kid that was a pretty tough kid, happened on the playground, and said, hey, what do you guys want to do? And they They said, if you don't mind trying it here, we'd love it. And if we need to go on, we're happy to, but let's try reduction in the office. So went over risks and complications associated with that. The main things that we're always worried about with any upper extremity injury is compartment syndrome, which is where basically after an injury, there's so much swelling that occurs that it starts to impinge within the compartment of the upper extremity. The nerves and the blood supply. So we asked them to look for any signs of paresthesias, of pallor, severe pain. Um, the Basically, if they're looking at their hand and they're feeling like things are getting more and more swollen and discolored, then we will often have them run up to the ER just to make sure that things are good. This is more of a complication or a concern that occurs post reduction and splinting or casting. Typically, we don't start off casting somebody after an initial injury simply because if you cast them, you've created an enclosed space and the swelling cannot expand. So they usually get splinted for the first at least several days after an injury and then transition to a cast thereafter. So we talk about that as a potential complication, associated nerve injuries, and uh, did a hematoma block on this patient. So for their pain reduction, a hematoma block is we take a needle and drive it directly into the fracture site. You pull back blood to make sure that you're in the fracture site. They're all going to bleed quite a bit. So you pull back and you get the bloody aspirate out. And then I usually use a combination of like 5 cc's of lidocaine and 5 cc's of Marcaine. And we'll inject into the fracture and just infiltrate it with a whole bunch of anesthesia. Give it about 5-10 minutes. And most of the time, their pain has substantially reduced at that point. It's really not hurting them too much, which makes then moving on to do uh, a reduction much easier. So hematoma blocks are something that pretty much any provider can feel comfortable attempting. Typically, I'm going on the dorsum of the wrist because we're not worried about hitting into the ulnar nerve or median nerve. At this point, the posterior interosseous nerve that supplies the wrist extension is minimized. There's not it's distributed the majority of its nerve supply at that point. And so going in and pulling off that blood and then injecting a large volume of anesthetic into the area gives them good analgesia. And then did the reduction. This is the post imaging in a splint. And we can see we got a nice reduction out of it. And then just saw them a little while ago out of the cast at this point and doing. So just being aware of potential nerve injuries, compartment syndrome. The EPL is something that you should always check. The EPL brings your thumb up. It often crosses across through here. And because of fracture patterns, sometimes that tendon will get rubbed or kind of raw across the fracture site and can actually rupture. So on every check that you're bringing somebody out of a splint or a cast, just have them with their thumb up and resist it and make sure that they have that good thumb extension. And then physeal injuries is the other consideration with this. I have a slide on the Salter-Harris fractures, and we don't need to go a ton into that per se, but it's good to know the different types of fracture patterns. I'll just go through one other case real quick, and this is a lower extremity one, but it's just an example of another way to treat these. This is a guy that was playing basketball and came in and had his talonavicular midfoot dislocate on him. And so in clinic, we did a block, went and blocked femoral and sciatic nerve on him, actually, just so he had complete analgesia, didn't have to fill the pain as we did the reduction, but using an ultrasound, finding local nerves. And so for our sports providers that do quite a bit of ultrasound, don't forget the power of just ability to do an ultrasound guided block and provide some significant pain relief for patients with that before doing a reduction. And then it made the reduction pretty easy to get that back into place. The Salter-Harris fractures, just briefly, the physis is your growth plate. The epiphysis is the distal portion that goes to the joint. The metaphysis is the proximal portion that goes to the length of the bone or the diaphysis of the bone. So a normal physis, a type 1 fracture will be through the physis that you'll get a fracture. sometimes with or without displacement. There's a lot of times that we're not really sure. We can't see that they had a type 1 fracture, but they hurt right at the growth plate. And so we'll often call those a type 1 physeal injury. A type 2 is just through the metaphysis and into the physis. A type 3 is through the physis and into the epiphysis or into the joint. So obviously these ones we're going to watch a little bit closer because now it's gone into a joint. So we worry more about the cartilage that caps the bone. A type 4 is through both metaphysis, physis, and epiphysis. And then a type 5 is a crush of the physis. A type 5 you're going to call based off of having contralateral imaging. So you're going to compare both sides, and then you can see that the physis on one side is much more narrowed. Um, on the majority of these, most type 1 fractures, if they need to be reduced, you have to reduce them, but otherwise they're treated non-operatively, as are type 2. Young kids fractures, we're going to watch just a little bit longer, maybe do like a 3 or a 6 month follow-up, because if it's going into the growth plate, you can have some growth arrest that occurs on these. More concerning around like the knee is where we'll often see some of those from like a trampoline fracture. So those are the ones that we'll just watch a little bit longer to make sure that they don't get a weird growth arrest and start having their leg bow off and do weird things. The wrist has much less likelihood of that, but I'll still bring them back, even though they heal really, really fast in the majority of cases. I think I've gone through enough uh, exciting stuff there. The hand injuries we're not going to do today. I would say that hand injuries um, are variable on how we treat them. For the most part, I would strongly encourage that if you have a question on hand, that you reach out to a hand provider. It's an area of the body that is very important that it works well. I would say a vast majority of hand is non-operative, but when it is operative, it can make a big difference if it's treated correctly or incorrectly. So feel free to reach out to a hand provider, or always do a separate lecture on that in the future to go over acute management of hand injuries. I'm going to stop there and take any questions that people have. I realize how broad that topic is. Hopefully that's helpful on just the comfort level of when you treat things operatively versus non-operatively, and give you just a little bit more idea on things that you might consider adding to your practice, or ways to help provide additional pain relief for patients that come into the office.
Excellent job, Dr. Monson. Thank you so much. Lots of great information for our providers. Love the humor and the hints. They were great. And if you have a question, please put that into the chat. While we're waiting for those, just a quick reminder from Dr. Ottaway. Many thanks. Great lecture. Thank you, Dr. Ottaway. Quick reminder, next Friday is Dr. Rawlings' presentation to round out the Ortho Symposium for primary care providers. From Dr. Arja, good job. Thank you. Thank you, Dr. Arja. I'll give it one more minute here. From S. Windsor, Mike Tyson equals die punch. Awesome. Thanks for a great presentation. Not too many Friday grand rounds where we get some giggles, so I love it.
Good. Thanks for letting me present, everybody. Feel free, you have my email. Feel free to send me an email or give me a text message or call if you have any questions.
All right. And with that, we're going to call it. So thank you so much, Dr. Monson. Really appreciate you and your time. Thank you for joining us, and everybody have a wonderful weekend. Thank you.
Thanks.